Hi, everyone. Thank you for joining us today. We're going to spend some time, just a few minutes, letting people in, and then we'll get started. Just give it one more minute to see if anybody else joins us. And if not, we'll get started. All right. Looks like we're not having anybody else quickly coming into the room. And I know we only have an hour and we are covering a lot of material today. So I want to go ahead and get started. Thank you, everyone, for joining us. This is the last in FHJP's October series on Medicaid. We partnered with Justice and Aging to cover some topics related to Medicare basics, Medicare D-SNPs, which are dual plans for managed care plans for dually eligible individuals eligible for Medicare and Medicaid. Then last week, we heard from Eric Carlson, talk to us about rights related to nursing home discharges. And then we're going to finish up with some hot topics in Medicaid eligibility and appeals. A reminder that the last few trainings that I mentioned did qualify for CLE credits, and we'll be providing that information at the end of this training. So I just wanted to tell everyone briefly, for those who are not familiar, what Florida Health Justice Project is. We are a nonprofit law firm that provides assistance to individuals, legal assistance to individuals who are low income and need access to healthcare eligibility and coverage. Our primary focus is Medicaid eligibility, but we also work on marketplace assistance as well as financial assistance programs and charity care. I am the legal director of Florida Health Justice Project. I direct both we do individual administrative advocacy through Medicaid appeals, which is mostly what I'm going to touch on today. But we also do a significant amount of systemic litigation. So identifying issues that we can bring cases around to change policy that is preventing equal access to healthcare in Florida. With me too is our newest attorney and board-certified fellow, Nicole LaRock, and she'll tell you a little bit more about that fellowship when she presents. Next slide, please. So what we're going to cover today, we're going to talk about first, just general provisions of Florida's Medicaid program, give you guys an introduction for those who are mildly familiar or not familiar at all. And that's going to include an overview of Medicaid eligibility for Florida. We're kind of rare now. A quick overview of filing appeals and conducting hearings. What kinds of services Florida's Medicaid program covers. And then just touch briefly on Medicaid managed care. And in particular with Medicaid services and Medicaid managed care, we're going to talk about some hot topics, including some litigation development on FHJP's front, as well as some upcoming changes to the managed care plan, to the managed care system under the new 2025 procurement. And then Nicole's going to give you an update on the public health emergency Unwind, where we're at the end of the Unwind, which Florida wrapped up a few months ago. And she's also going to focus on some good changes to Medicare Savings Programs and how they relate to that PHE Unwind. Next slide, please. All right, so as promised, we're starting with the Florida Medicaid program's just broad eligibility overview. To be eligible for Medicaid in Florida, there are really three main components that you have to meet, requirements that you have to meet. You have to meet technical requirements. And that can range from a lot of things depending on what category of Medicaid you're applying for. For example, if you're a parent or caretaker applying for Medicaid under a family-related category, then you're going to need to cooperate with child support enforcement in order to qualify. But three big technical requirements that everybody who's applying for Florida Medicaid must meet are you have to have either US citizenship or meet a qualified immigrant status. And we are available for technical assistance to those individuals who want to discuss qualified immigrant status further. And that reminds me that I forgot to mention on the welcome slide that we're going to take questions at the end. But if anybody has a question throughout the training, feel free to drop it in the Q&A and we'll address it at the end. So as I said, you need US citizenship or qualifying immigrant status, and then you have to establish Florida residency. Although Florida residency is a very low bar, there's no minimal time amount in which you have to be in Florida to establish residency for the Medicaid program, and you can simply just have an intent to remain. Then you have to meet a category. So this is where Florida is is an outlier at this point as compared to most of the states in the US. And we are an outlier because you have to meet a category in order to qualify for Florida's Medicaid program, whereas most states, the vast majority of states in the US have expanded their Medicaid programs such that the only requirement to participate in Medicaid is an income requirement. But again, in Florida, we do not have that. You have to meet a category. And DCF really breaks that down. Department of Children and Families, who determines Medicaid eligibility, really breaks that down into two main buckets. And those two buckets, which I'll talk about further in just a second, are family-related Medicaid or disability, what DCF terms as SSI-related Medicaid. And I'll touch more on what categories fall under those two big buckets. But that's really how the Department of Children and Families conceptualizes Medicaid. Then there's child and care Medicaid, but we're not going to get into that today. That touches on foster children and children who are formerly part of the foster system. And then again, so eligibility overview, I'm talking about the main components that every person who's applying for Florida Medicaid must meet. That last one's going to be a financial requirement. And that is going to be, you'll see in a couple minutes that the category of Medicaid that you're applying for or may be eligible for is going to drive what financial requirements apply. A note that if you're applying for a family-related Medicaid category, then there is going to be no asset test. There are no asset requirements for family-related Medicaid after the Affordable Care Act. Next slide, please. Okay, so talking a little bit further as promised about those large buckets. Remember, we have two of them. We have family-related Medicaid and we have SSI-related Medicaid. For family-related Medicaid, some of the categories that fall under that are going to be children, those in low-income families, and I'll talk more about the financial requirement aspect in a second, noting that eligibility limits decrease as the child gets older. And then the other two main categories that fall under this family-related Medicaid coverage bucket are low-income parents and caregivers, as well as those that are 19 and 20, even though those technically fall under low-income children. They're kind of grouped together because of the income limits with the low-income parents and caregivers. And then pregnant women, including those who are postpartum. Next slide, please. So for just to kind of drive home the concept that I just mentioned, which is the financial requirements are going to be dependent on what category of Medicaid you're applying for. I think this chart does a good job of illustrating that concept. And if folks aren't familiar with this chart, we find this chart in the DCF, Department of Children and Families, ESS, Economic Self-Sufficiency Manual at Appendix A7. And then there's one for that other big bucket, SSI-related Medicaid at Appendix A9. After this presentation, we will be distributing the slides, and each of those slides will have hyperlinks to the DCF ESS policy manual. Not only is this chart helpful, but for those who are able to, lawyers and other professionals who are able to navigate the policy manual itself, It can be a really useful resource in helping guide people through their Medicaid eligibility. So I would encourage anyone who's interested in this type of work to dig deep into the DCF ESS policy manual. But turning back to the subject at hand, income limits are driven by what category Medicaid you're applying for. A great example of this, looking at the chart, you'll see for infants under the age of 1, highlighted in orange, that if you're in a household of 2, let's say, the income limit's going to be at 200% of the federal poverty limit, or $3,407 a month. Then you, of course, add the standard disregard and the Magi disregard over there on that farthest to the right column highlighted in green to come up with the total income limit. But when you turn 1, notice in the, I guess that's yellow, gold yellow chart, that you're dropping from infants under 1, 200% FPL to 133% FPL. So as the child gets older, just as I said, that income limit will decrease. The amount of money you're allowed to make and still qualify for Medicaid will get lower and lower as the child gets older. To the point where if you skim all the way over to the left to the light blue column with parents, caretakers, and children aged 19 and 20, you're going to see that the income limit drastically reduces to no more than $241 a month, plus you add the standard disregard and the Magi disregard. But you're looking at a very low income limit for a parent, a caretaker, or a child aged 19 and 20 to qualify for Medicaid. Next slide, please. The second big bucket, so we just covered family-related Medicaid. Now we're going to cover SSI-related Medicaid, which is really any category of Medicaid where you have a disability that would qualify you through the Social Security Administration. So it's not just having a disability. It's not just having an illness. You need to have a disability that rises to the level of the Social Security Administration standards. And anybody who does that work understands that's a very stringent standard. But the major SSI related coverage groups, and I do want to be clear here, even though you have to meet the SSA level or definition of disability, that doesn't mean you have to go through the Social Security Administration to apply for Florida Medicaid. DCF must accept and evaluate Medicaid applications separate and apart from any application through the Social Security Administration. And unfortunately, that I think is a common miscommunication from DCF that one has to apply for Social Security in order to be eligible for a Florida Medicaid program. While you do have to apply for all potential benefits, you do not have to enter through the Medicaid system via the Social Security Administration. You can go directly through DCF's door. But some of those major SSI related coverage groups would include SSI, Supplemental Security Income. So that would be an instance where you apply for Supplemental Security Income through the Social Security Administration, then you automatically qualify for Florida Medicaid and you don't actually have to apply directly through DCF. Meds AD, which is a coverage group for those who are just slightly over the SSI limits but are disabled and do not have Medicare. And Nicole LaRocque is going to talk a little bit more about that category. But essentially, it's 88% of the federal poverty limit and meeting a disability level from the Social Security Administration without having to apply directly for Supplemental Security Income through the Social Security Administration. I'll give you an example of this. I just wrapped up an individual case where there was a 19-year-old who has qualified for $1,000 worth of benefits on his parents' income records because he has a disability. He would not automatically qualify for Medicaid because he's not receiving Supplemental Security Income. He's receiving Social Security disability based on his parents' earnings records, but he's under 88% of the federal poverty limit and he's not receiving Medicare. So he is eligible for Medicaid through the Meds AD program. Then there's ICP, or Institutional Care Program. That's going to be your nursing facility. Medicaid. Same limits would also apply for home and community-based services. Those are your long-term care budget waivers mainly, as well as hospice. And then the Medicare Savings Programs, those are not actually going to give you full Medicaid. What they're going to do is they're going to pay for your Medicare premiums so that you can keep that little bit of extra money that Social Security would otherwise withhold to pay your Medicare premiums. And then for qualified Medicare beneficiary, you will also get the benefit of enhanced billing protections. But none of the Medicare savings programs are going to give you an entry ticket into getting full Medicaid coverage. That means you won't get all of the services that Medicaid covers. A great example, of course, is dental, because Medicare doesn't cover dental, Medicaid does, but on a Medicare savings program, you're not getting full Medicaid, so you wouldn't get that Medicaid dental coverage. Next slide, please. And this is Appendix A9 that was promised just a second ago. This is the corollary income chart. I just showed you the one for family-related Medicaid. Again, children, pregnant women, parents and caretakers. This is the one, this is the chart that would apply for individuals who are eligible on the basis of their disability, that disability determination through the Social Security Administration. And these are some of the categories I just covered. You can see, for example, 88% of the federal poverty limit for those who are Meds AD eligible. So in a household one, you can't make more than $1,105 a month. I shouldn't say make. You can't have income that exceeds $1,105 a month. And notice, unlike family-related Medicaid, you have an asset test. So you also can't have more than $5,000 in assets. Cash, stocks, bonds, some property. The rules get really nuanced. So that's something that you can reference through the DCF ESS policy manual if you want to know whether something qualifies as an asset. But then look at HCBS Medicaid. So there, the income limit's going to be much higher if you qualify for a waiver and get off the wait list and enrolled in a waiver. You're going to have an income limit of $2,829 that applies. Compare that to the 1,105 in Meds AT. But then your asset limit goes down, although there are some rules that as to what counts for an asset and what may or may not be excluded as an asset. Just a general overview. Next slide, please. Then if you don't qualify based on income, if you're over income, either for family-related Medicaid or for SSI-related Medicaid, but you're meeting one of the categories, you're a child age 5, you're a person with a disability, but you based on the Social Security Administration, but your benefits are too high to qualify, for example, Meds AT, then you may be enrolled in the medically needy program. And what the medically needy program is it establishes a share of cost. So there's a determination made about how much based on your income you would have to establish through unpaid medical bills or uncovered medical bills, I should say. And then that number, let's say your share of cost is $1,500 a month. So DCF calculates how much income you have monthly, and then they subtract a certain amount. Out pops your share of cost. Let's say, again, it's $1,500 a month. Then in order to meet that share of cost, what you need to do is provide to DCF unpaid or uncovered medical bills. So it's okay if you're paying out of pocket. Those still count. It's just the question is, do you have any insurance that's covering these bills? If you do not have insurance to cover the bills, if you have uncovered medical bills, you submit those to DCF. And at the point that those bills meet or exceed your share of cost, in my example, $1,500, the Medicaid will open up on the date that you meet your share of cost and uncovered medical bills, and will remain open through the end of the month. Importantly, you do not have to pay the medical bills between it's not DCF, and even I kind of liken it to a deductible, but it's not as though you have to pay $1,500 out of pocket before you're allowed to use medically needy. You simply need to have $1,500 in uncovered medical bills, submit that to DCF, and at the date that it reaches the amount of $1,500, you're going to get Medicaid from that date until the end of the month. And if that was a little bit of a bumpy explanation of share of cost, there is a pretty decent one that DCF publishes, and we have that hyperlinked there. Next slide, please. So some important concepts in terms of DCF eligibility determination. So I think you've heard me say kind of ad nauseum at this point that DCF, Department of Children and Families, is the one who determines financial eligibility for Medicaid. Now, for certain waivers, for example, the long-term care waiver, clinical eligibility is determined elsewhere. So that is through the Department of Elders CARES program. For iBudget waiver, the waiver designed for people with developmental disabilities, APD, the Agency for Persons with Disabilities, is going to determine your clinical eligibility. But once you're released from the wait list and the clinical eligibility is determined, then they're going to send you to Department of Children and Families, and DCF is going to do every financial determination of Medicaid eligibility. There are some of the governing rules behind DCF determinations of eligibility. It's going to be Florida Statute 409.9, that particular section of 409, Chapter 65A-1 of the Florida Administrative Code. And then, as I've mentioned a few times now, the DCF ESS Policy Manual, which is DCF's Operating Procedure 165-22. Lots of good information in the ESS Policy Manual. Other important concepts in DCF, or excuse me, Florida Medicaid eligibility determinations are no wrong door. So as I was kind of pointing out with SSI related Medicaid bucket just a second ago, there is no wrong way to apply for Florida Medicaid. You can do it in person, over the phone, via mail, through what we would always recommend, DCF My Access accounts, which is an online portal. And the reason why we recommend that is it maintains the best record of your Medicaid application. You can also apply for this through the Social Security Administration if you're applying for a disability related category, and the Social Security Administration will refer your application to DCF. As well as for any category, you can apply through healthcare.gov. And then again, if healthcare.gov identifies that you may be Medicaid eligible, they're going to do a direct transition of your Medicaid, of the ACA or marketplace application to DCF. And then one other concept I just want to touch briefly on in terms of eligibility determinations. And I emphasize eligibility because the concept of reasonable promptness applies both to eligibility determinations, so determining whether someone can open the door and enter into the Medicaid program. It also, reasonable promptness applies to accessing Medicaid services, the timeliness of it, once you're found Medicaid eligible. But for eligibility determinations, there's the law that governs on the screen. DCF has 45 days to process a Medicaid application for one of those family-related Medicaid categories. They have 90 days if the application is related to a disability-related category or an SSI-related category, as they call it. Importantly, to apply for Florida Medicaid, you do not have to do an SSI application ever. Now, you might have to apply for other benefits as you might be eligible for them. For example, let's say you're an adult with a disability and your parent is passed away or retired, you may qualify for some kind of Social Security benefit. And in that instance, DCF can ask you as part of the Medicaid application to apply for those benefits. But an SSI, Supplemental Security Income application, is not required, no matter what someone at DCF tells you. And I do want to point out on applying for all other potential benefits, that falls under 42 CFR 435.608. That regulation says you must apply for all benefits except SSI that you're potentially eligible for in order to qualify for Medicaid. CMS recently eliminated that requirement. It doesn't take hold until 2026, so we have some time for DCF to get up to date to comply with that. But I do, for the more consistent Medicaid advocates on this call, I want you to be aware that as of 2026, DCF cannot require that someone apply for any other programs they're potentially eligible for. And I have a feeling it's because of this SSI confusion that the CMS decided to eliminate that requirement. Next slide, please. All right, just some important know your rights aspect of eligibility determinations that I just want every advocate on this call to be familiar with, because they're really important and they're really powerful in terms of advocating on behalf of your client. The first concept is something called an ex parte review. And that concept is that when an individual is switching from one Medicaid category to another, or I should say it this way, When an individual is being redetermined or reevaluated for Medicaid eligibility, the state is obligated, absolutely 100% required, to determine whether that individual is eligible for any other category of Medicaid. So I'll give you an example. A child is receiving supplemental security income because they have a disability. And for a while, their parents' income and assets met the SSI criteria through the Social Security Administration. But dad gets a promotion, a little one, but a promotion nonetheless. And that puts the child over eligibility for supplemental security income. So they lose Medicaid on the basis of receiving SSI. Prior to terminating that child's eligibility, so they have to continue the eligibility through the process of review, DCF must determine if that child is eligible for any other category of Medicaid. So let's say this is a child who's in a household of 5 and they're between the ages of 1 and 5. You're going to go back to that Appendix A7 and you're going to see that their income is below the income limit for a household of 4. For a child of that particular age. And you're going to know that DCF, when they're doing that ex parte review, needs to continue Medicaid. And then they just need to find the child eligible under that family related or MAGI category. Not at any point should that child lose Medicaid. That's the concept of ex parte. And related to that is what I'm talking about, which is aid paid pending. What that means is the benefit must continue during DCF's review. What it also means, which we'll touch on a little bit more in appeals, is if a person timely appeals or DCF fails to send notice of termination of that person, then DCF must continue the Medicaid eligibility through the pendency of an appeal. Then there's a couple of other important concepts. One of them is retroactive eligibility. And I think it's important to not confuse retroactive eligibility with eligibility that establishes an onset at the time the person was eligible. So if a person, for example, applies in April and is denied in May, successfully appeals in June, such that they should have been eligible in April, and DCF opens Medicaid from April ongoing, that's not retroactive eligibility. That is simply DCF finding the person eligible from the date they filed an application. Retroactive eligibility is the concept that someone who applies can be eligible for 3 months prior to the initial application. Unfortunately, in Florida, the only people who qualify for getting that 3-month bonus period prior to their initial applications. So in my example, someone who applied in April could potentially be eligible for retroactive Medicaid if they otherwise meet all the eligibility requirements in March, in February, in January, and hopefully I got that right in terms of my 3 months. But so they apply in April and then they get 3 months prior. That's retroactive eligibility. Unfortunately, in Florida, we have eliminated retroactive eligibility for non-pregnant adults. So seniors, people with disabilities do not get the benefit of retroactive eligibility in Florida, although children do, as do pregnant people. And then one more important concept, and kind of along the theme of our hot topics in Medicaid eligibility, is continuous eligibility. And this is the concept that even if someone experiences, once they've been found eligible for Medicaid, even if someone experiences a change in circumstances. So for example, a child who is 15 becomes eligible for Medicaid in April of 2024, they will be continuously Medicaid eligible for 1 year until April of 2025, regardless of, say, mom gets a giant promotion and is now making $100,000 a year. It doesn't matter. The child gets that Medicaid uninterrupted for a year, and not until after a year can DCF or the state reevaluate that child's Medicaid eligibility under the change in income circumstances. In Florida, we have continuous eligibility. Recently it changed. Now we have continuous eligibility for children 0 to through age 18. And then we also have continuous eligibility for women 12 months postpartum. So regardless of what occurred with the pregnancy, giving birth, having a miscarriage, whatever it might be, 12 months postpartum, a woman is entitled to continuous Medicaid eligibility. So it doesn't matter her change in circumstance. Their change in circumstance. Next slide, please. Okay, and I'm just going to touch briefly on due process and appeals. So we still have quite a bit of substance to get through, and I want to make sure Nicole has adequate time to get through hers. Um, the main question I get when I go around talking about filing a Medicaid appeal is why do it? Why not just reapply for Medicaid if DCF gets it wrong? And my number one reason for filing an appeal, and in fact, you can file a new application at the same time, nothing's stopping you from doing that. But why you need to file an appeal is because of corrective action. So DCF typically, and they testified at a trial that FHJP had recently in July, they testified at a trial that DCF does have the common practice of if they realize there's an error in a previous application, they will fix it back to the date of that error. But they are not legally required to do that. The only way they are legally required to fix an error back to the date of an application is if you file an appeal. And you can see that from the language here under 42 CFR 431.246. So if the hearing decision is favorable, or if the agency decides in favor of the applicant or beneficiary prior to the hearing. What that rule means is you better have requested a hearing in order to be entitled to corrective action, and DCF doesn't have to do it unless they feel like it, unless you filed an appeal. So you're really protecting someone's rights. You're really protecting all potential benefits they're eligible for by filing an appeal. Also, filing an administrative appeal with the Department of Children and Families really isn't rocket science. Now, the underlying eligibility and determining that can be much more nuanced and require expertise. But filing the appeal itself is not hard. And we have lots of resources to learn about how to do that. But you can simply send an email to DCF's Office of Appeal Hearings. They also have an online portal in which you can submit one. You request it over the phone, although I will emphasize that we at FHJP strongly encourage everyone to file it via email so you have a record of filing that appeal, because as one would imagine, sometimes DCF loses an appeal request through a telephonic or other method. We have some great resources on our website, both hyperlinked here, and then we're going to have a resources slide at the end of our presentation that really go in depth into representing a person on an appeal or representing yourself on an appeal, including this simple fact sheet here that's really good to give someone on a quick turnaround, as well as our Medicaid Appeals Toolkit, which can be found on our website and goes step by step through representing yourself or someone else on an appeal. And then, of course, as I just mentioned a few seconds ago about aid paid pending, if you timely appeal, if you appeal prior to the termination of the benefit, that's set out in the notice. So I get a notice that says my Medicaid will end on June 30th. If I appeal on June 30th or prior, then I get the benefit of aid paid pending. I get continued benefits through the pendency of the appeal. We also want to note, based on our Cheyenne D litigation, that DCF made a change in some of their notices of case action, but not all of their communications with beneficiaries, that you are not required to pay back benefits for aid paid pending unless DCF finds fraud on your part. And then again, the notices of case action due to our Cheyenne D notice litigation, DCF changed that to say may have to pay back benefits only if you're subject to fraud for having requested them, but they don't have that in every communication. It can really cause confusion. So that's where you can do a good job with your client is tell them, no, absolutely, DCF policy is that you are not required to pay back benefits for aid paid pending unless there's a finding of fraud. And then here are some of the ways that you can conduct. We like to request teams here at Teams hearings here at FHJP so we can have eye contact with our client and with the hearing officer. And it's a full-blown trial if you want it to be. You get the opportunity to do discovery, you can exchange exhibits, you get cross-examination, we do depositions. So we really use to our advantage the administrative appeal system, I should say, use to the advantage of our clients. And then just one more quick note, in the acknowledgement of hearing request, there will always be the name of an individual on DCF's side who is assigned to the case. Sometimes those people are really knowledgeable, sometimes they're not, but it's always good to reach out to that person if they don't reach out to you, even though they're required to try to work out the case informally. Um, Next slide, please. What if your appeal deadline has passed, but you need to cover those uncovered medical expenses that only Medicaid can cover, and you know you applied for and were eligible in a particular month, you just didn't file an appeal because at the time you were in the hospital and couldn't, or at the time you just simply didn't have the electronic resources to successfully file an appeal. Well, under 65A-1.702, which is cited there at the bottom of the slide of the Florida Administrative Code, we do have, as every state does, a good cause exception to missing your appeal deadline. As you can tell from this very busy slide, it's an involved process, but for those folks who are lawyers or more experienced advocates on the call, I do just like to flag this rule. If a client or someone you're assisting has missed an appeal deadline, read through this carefully and see if they meet a good cause exception. I do find that DCF is very good about allowing good cause exceptions if requested. I think most people at DCF, even though it's a hard job and they get it wrong a lot, they do want to try and get it right. So you can give them this citation if someone misses an appeal deadline and ask them to work with you to get the decision right and fix it for the person. Next slide, please. So this is just generally, we've gotten through all of these complex processes. We've gotten the person Medicaid eligible. You're Medicaid eligible. Now what happens? Well, you get Medicaid coverage, and that's driven by the laws that I cite here. There are mandatory services every state must cover if they are participating in the federal Medicaid program. And then there are optional services. There are services that the state maybe wants to cover, maybe doesn't, and the federal government gives them the flexibility in opting into that. The document that you can determine whether a state has opted into an optional service is called a state plan. There's one on the Agency for Healthcare Administration's website. You can also access our Florida State Medicaid plan through cms.gov. So again, on Agency for Healthcare Administration or AHCA's website, as well as cms.gov. Once a state opts into covering a service that is optional, then it becomes mandatory. Then they have to provide it for everyone as long as it's medically necessary. And then mandatory states have no choice. There's also the concept of comparability, which means that you can't have non-medical reasons for parsing out who qualifies for a Medicaid service and who doesn't. So a great example of this is a case, Davis v. Shaw, federal appeals case, where the state was covering compression stockings for people with, I'm making this up, vascular disease, but did not cover compression stockings for those who needed it as part of physical therapy after being discharged from a hospital. That violates comparability. This compression stockings are medically necessary. It does not depend on your diagnosis. And if you don't cover it because they're medically necessary and you're trying to parse it out through a diagnosis, then you're in violation of comparability. Remember though, long-term care, HCBS home and community-based services waiver, part of the waiver is waiving comparability. And so that's why you see that individuals who have specific diagnoses get access to the services that the waiver covers. Just a couple financial protections. Of course, in Medicaid, there are no premiums and they're minimal. And in fact, in Florida, there's no cost sharing. And then any provider who participates, who signs a contract to be a Medicaid provider in Florida, they cannot bill. And if you know of individuals who are in Medicaid that are being billed by their provider, we have template letters you can send the provider as to how that's illegal. And we always would recommend getting into contact with a consumer lawyer. And then that reasonable promptness concept that I just discussed, just like with eligibility, once someone's in Medicaid, the state has roughly, it's reasonable, given the circumstances, that's the standard, but roughly the rule of thumb is 90 days in order to give someone access to services. Next slide, please. Okay. So a few more updates in terms of FHJP advocacy and litigation that I want to touch on before turning it over to Nicole. As I just mentioned, to have coverage, to have access to services under Medicaid, they must be medically necessary. So even though you're Medicaid eligible and Medicaid generally covers a service, it has to be personally medically necessary to you in order for Medicaid to be on the hook to pay for or cover that service. Under EPSDT though, and Nicole, could you just flip to the slide 15 really quick so I can, that definition of medical necessity that applies to everyone to determine whether or not Medicaid has to cover a service for you, that's going to be at 59G-1.010. Okay, Nicole, are you able to flip back? Thank you. So, but for children under age 21 who are in Medicaid, we need to remember that the standard for determining what is medically necessary, as well as what services are covered, is much broader due to the EPSDT protections. So 3 main things I'm going to point out about EPSDT, early and periodic screening, diagnosis, and treatment. For Medicaid enrollees under age 21, the state must cover necessary healthcare, diagnostic services, treatment, and other measures to correct or ameliorate. That's the standard, okay? So the standard is this medical service going to correct or ameliorate a defect or other limitation based on a child's diagnosis? What this means in practice is a few things. No limits on the amount of services as long as the services are medically necessary. For example, a child who needs 10 hours of applied behavior analysis a week, the state cannot come back and say, we only cover 5 hours. They have to cover all 10 hours as long as the medical necessity is established. Another point, those mandatory services and those optional services I just talked about, all optional services, whether or not a state has elected to cover them, must be covered for children under age 21. So any optional service, whether or not the state wants to cover it for an adult, have to cover it for a child. And then finally, the state, in looking at correct or ameliorate, must align that with their definition of medical necessity. And that's the litigation I'm going to talk about in just a second. But I do want to note there are some limits on EPSDT, including that the service cannot be experimental or investigational. Next slide, please. Oh, and actually, I do want to point out, sorry, Nicole, I do want to point out the state can cover a less costly benefit, but that service better be equally effective. So if they want to cover a specialty medical bed that's less expensive, that specialty medical bed better have all of the things that the child needs that are medically necessary, even though it's the cheaper version. Next slide, please. Okay, so our litigation, WBV Marstiller, challenged the medical necessity rule under 59G-1.010, saying it does not align with correct or ameliorate. It does not align with EPSDT. It gets really mushy what that means. And in fact, we just saw a really bad case come out of the 11th Circuit, MHV Commissioner of the Georgia Department of Health, Community Health, which is not a good case. And if you really want to dig deep into the concept of EPSDT, I recommend you go read that. But what we did do is the most offensive aspect of Florida's medical necessity rule, that the service must be necessary to protect life, prevent significant illness or significant disability, or to alleviate severe pain. We reached a settlement with the state, said that standard can apply to kids. And they went through formal rule adoption. They changed the notices of adverse benefit determination, those notices that people get when a service is determined or may not be covered. In this portion of 59G-1.010 can no longer apply to children under age 21. But stay vigilant, because we're seeing all kinds of ways in which they're using the other portions of the medical necessity rule to run around that correct or ameliorate standard. Rule of thumb, kids under age 21 on Medicaid should get the services that their physicians are recommending. Next slide, please. And then talking about other recent service updates, we had some other successful litigation that just wrapped up, Mesa v. WIDA. which was a class action challenging the state's failure to cover incontinence supplies, which are a mandatory service, not an optional, a mandatory service. Prior to our litigation, if you wanted to be an adult who received incontinence supplies, you had to be on a HCBS waiver. That's no longer the case. If you're a Medicaid eligible in Florida and you can establish that incontinence supplies are medically necessary, then the state must cover regardless of age. And there's some hyperlinks there that explain that case better for anyone who's curious. And then speaking of waivers and what happens with a waiver, we also just, well, this was a little while ago, but haven't trained on it, so we wanted to get the word out. Jones v. Agency for Healthcare Administration, which is a Division of Administrative Appeals case on the basis that ACA was acting on an unadopted rule. There is a provision of Florida statutes 409.9793 that allow F1 that requires the state to give children who have 24-hour care needs, they're entitled to automatic enrollment. They do not have to wait to get onto the long-term care waiver. The state was saying you had to have private duty nursing authorized and in place in order to qualify for the automatic enrollment. That's not what the statute says. So we challenged, and now there's a new process, hyperlink there. If you want to learn more, if you have clients in this situation, that allows a direct referral for 18, 19, and 20-year-olds who have 24-hour care needs through the Department of Elder Affairs CARES process to get waiver enrolled. And I'm going to go through this as quickly as possible. Medicaid managed care. Everyone in Florida, for the most part, there are a few who I have listed here, but most everyone in Florida on Medicaid has to participate through Medicaid managed care. You're not getting your Medicaid through the state, you're getting it through a private plan, Sunshine, Humana, United Health, etc. And that's that contractual relationship between the state Medicaid agency and those private MCOs that I just mentioned, like Sunshine. There's a model contract on the Agency for Healthcare's website. If you're frustrated with your managed care plan, or you have a client who's frustrated with their managed care plan because they're not doing what they're supposed to be doing, that contract, that model contract on ACA's website is a gold mine in finding the rights of your clients and helping them navigate through the process, which you do through ACA complaints. We have hyperlinked here how to file an ACA complaint and successfully navigate that process. But really that model contract is just a wealth of information about your client's rights. Next slide, please. All right, one last slide for me, and then I'll shut up and turn it over to Nicole LaRock. Under Medicaid managed care, we have a new procurement process. So every given set of years, I believe it's 5, the state renegotiates its contracts with these private managed care plans, Humana, United, Sunshine, etc. Some get awarded contracts in that new procurement process, some don't. A lot this go around in our 2025 procurement did not. I have hyperlinked there, the new plans, those who received contracts and in what regions. We've gotten a bit smaller. New contracts take effect, so individuals will start receiving Medicaid in this new procurement process under the new model contract for 2025, effective February 2025. There honestly are still a lot of unknowns. ACA is actually still going through the process of making sure that the individual contracts between MCOs are meeting standards. So it's ever evolving. Please know that FHJP is really dialed in on what's happening here. We're developing some new resources about 2025 procurement, and we will push those out. Please look on our website for updates. Auto enrollment, 2 major changes, and then I promise, Nicole, I will stop talking. 2 major changes. Auto enrollment begins November 2024. Voluntary populations, those who can opt out of managed care, will now be auto enrolled, and ABA services are being carved in. Thank you.
Thank you, Katie. So I'm going to switch gears a little bit and talk about the public health emergency, or PHE, and the protections it provided for Medicaid beneficiaries. Just a little background: under the Families First Coronavirus Response Act, states received increased federal Medicaid funding if they did not establish any new eligibility or enrollment requirements or restrictions, increase premiums, or require cost sharing for treatment or testing of COVID-19. So essentially, states cannot terminate Medicaid for anyone enrolled in the program during the public health emergency, regardless of whether they later became ineligible beginning March 2020 through the end of the PHE. This significantly increased the number of individuals covered by Medicaid during this period. We saw increases of approximately 2 million enrollees between March 2020 and March 2023. So where do we stand now? The Consolidated Appropriations Act decoupled the public health emergency from the continuous Medicaid coverage requirement. And as a result, continuous coverage protection ended on March 31st, 2023, allowing the state Medicaid agencies to begin that redetermination process. The state had 1 year to complete the redetermination process, with data indicating that around 5 million enrollees were reviewed. Redetermination occurred in stages, with those who were considered to have the greatest medical needs evaluated last. And as anticipated, during the unwind or redetermination process, there were substantial coverage losses. Recent data shows that Florida has disenrolled approximately 1.9 million individuals from Medicaid since the redetermination process began. And in a few slides, I'll discuss some of those groups that were greatly affected by the end of that continuous coverage. For now, this is the most recent table that FHJP has created, providing a status of the redetermination process, which is now ended. But this captures data from April 2023 through March 2024. And many of the figures that I was mentioning earlier can be seen here. Approximately 1.7 million enrollees were terminated. Around 700,000 were deemed ineligible. And one major concern that we've had is even more of those individuals, around 1 million beneficiaries, were terminated for procedural reasons. So now going back to those impacted groups. As expected, as I mentioned, some of these beneficiary groups were disenrolled at the most significant rates. And these included former foster care youth who turned 26 during the public health emergency. And because under standard Medicaid rules, children who were in foster care and enrolled in Medicaid when they turned 18 while living in Florida are eligible for Medicaid only until they turn 26. And they may still, it's important to know that they may still qualify if they fall under another Medicaid coverage group, such as if they're disabled, pregnant, or a parent. Another group is 19 and 20-year-olds. When they became that age during the public health emergency, they've often become ineligible because although they can remain on Medicaid, the household income limit drops significantly, and their eligibility then largely turns on whether they file as a separate household of one, or are they still being filed as a dependent. And unlike their children who are now 19 and 20, parents of those 19 and 20-year-olds who no longer have another child who's younger than 18, they have lost coverage unless they are also eligible for coverage under a different type of Medicaid. And lastly, Katie brought up this group before, Meds AD recipients who are now on Medicare and became eligible during the public health emergency. They've also been impacted by the end of continuous coverage. And all of these bullet points are links to additional handouts that we have on our website that can provide more information about each of these groups. I know Katie mentioned a little bit about the Meds AD group, but just for some background, that stands for Medicaid for Aged and Disabled, which is a program that provides coverage for low-income individuals who are either 65 or older or have a qualifying disability. This coverage group includes those who meet specific income requirements, as Katie alluded to earlier, and includes those who are subject to the 2-year waiting period for Medicare. And typically after an individual in the Meds AD coverage group becomes eligible for Medicare, they lose full Medicaid coverage. So enrollees whose Medicare began after March 2020 have had their eligibility whose Medicare began after March 2020 they have had their eligibility redetermined during the redetermination process and lost their Meds AD coverage. These enrollees should have received a notice from DCF informing them of their Medicaid coverage has ended and that they have been enrolled in one of the Medicare Savings Programs, specifically QIMBY or QMB, assuming that their income is still less than 100% of the federal poverty level. The notice should have also informed them of their enrollment in the Medicare Savings, Medicaid Medically Needy Program, specifying their share of cost. And it's important to note that some of these beneficiaries may be eligible for the Medicaid Long-Term Care Program if they need assistance with their activities of daily living. And this program can provide both nursing home care and home and community-based services. More resources about the long-term care program are available on the FHJP website. So although individuals who became eligible for Medicare during the public health emergency should have already transitioned by this point into the other programs they're eligible for, they should continue to make sure that their online access account remains updated. And it's also important to note that it's the period of open enrollment for Medicare. So enrollees are encouraged to review their plans and connect with the SHINE program for further guidance. And I have linked to SHINE at the bottom of this slide. For reference here, we have included a table from the appendix of the DCF program policy manual showing the current income limits to qualify for the 3 different Medicare savings programs, as well as the low income subsidy program, also known as Extra Help. And as Katie mentioned, these programs help lower the cost of Medicare premiums for Parts B and or A, and possibly deductibles and co-insurance for covered services. The Extra Help program helps cover some or all of the cost of the Part D prescription drugs. And at the bottom, there is also the 2024 Medicare premiums, which can change in the upcoming year. And for more information, we encourage you to check out our recent Medicare Basics webinar presented by Justice and Aging, which is available on our website, and I've also linked to it in the chat. And one of the positive changes that Katie alluded to earlier is a relatively recent change that shows relatively recent change to how DCF calculates family size for MSP eligibility. Previously, when determining an applicant's family or household size, DCF would only include those individuals whose income was counted for eligibility purposes. And so now the new rule is that DCF is supposed to use the total family or household size to determine the income limit that applies to that applicant. So what hasn't changed is that the income of the applicant, and if they're married, the spouse's income, are the only ones used to calculate the household's countable income. Dependent household members are not counted against the applicant. So to make this a little clearer, I'll give an example very briefly that's included in the handout linked at the bottom of this slide. Let's assume there's a 67-year-old applicant who's enrolled in Medicare and receives $1,500 per month in Social Security retirement benefits. The applicant lives with her wife, who has a part-time job earning $1,000 per month, her 21-year-old child earning $500 per month, and her 1-year-old grandchild. Under the old rule, only the applicant and the wife's income would be considered in determining the applicant's MSP eligibility and the applicable income limit. And if you look at the chart, that would have been $1,704 for QIMBY, for example. But under the new rule, the household size is 4 people because everyone is related by blood, and the adult child and grandchild depend on the applicant and her spouse for at least 1/2 of their financial support. So then under the new rule, the income limit for QIMBY would be $2,600. So this change makes it easier for an applicant to qualify for an MSP, since it will often increase the household size and as a result, the income limit. All right, and so one other thing another issue we wanted to bring up is that when duly eligible beneficiaries, that is those who qualify for Medicaid and Medicare, lose their Medicaid, including their MSP eligibility, the state is no longer required to cover the costs of Medicare Part B or A premiums. So unless the enrollee withdraws from Part A or Part and B, the default would be to continue their enrollment, which can result in a deduction from their Social Security benefits. And so typically there is a 2-month delay before this deduction is reflected in the individual's benefit amount, which means that the first benefit payment usually includes a 3-month deduction. So that's a deduction from for the previous 2 months as well as the current month. And enrollees should receive a notice from the Social Security Administration before the before the deduction in these benefits occurs. However, we do know that this reduction in benefits can create an extreme financial hardship for these families. So we want to highlight an important option for individuals who may have been erroneously terminated from their Medicare Savings Program and then later reinstated, as well as those who may have been terminated properly but are just still struggling to pay their past due premiums. So these individuals can seek reimbursement from Social Security for any withheld benefits due to the loss of premium assistance. These wrongfully terminated, as I said, it can be wrongfully terminated individuals as well as properly terminated individuals have 2 immediate options available by contacting their local SSA office or calling the SSA 800 number. And the first option is to request an installment payment agreement. And this is beneficial for individuals who cannot afford to pay the full amount up front. All that's needed is needed for them to attest of their financial situation, and then the SSA can set up an installment plan. Payments can be as low as $15 a month, and Social Security typically processes these agreements quickly, and that will allow them to reimburse most of the past due premium amounts within just a few days. And for those who are properly terminated, Social Security will refund the 2 months worth of premiums deducted from the payment of the benefit payment minus that first installment. The second option is to request a waiver of past due premiums, and to qualify, individuals must demonstrate extreme hardship. Individuals who receive SSI automatically qualify for the hardship waiver. Otherwise, this involves completing the Social Security Administration Form 632, which is linked here, and submitting the necessary documentation, which can be done online or at an SSA office. And if approved, the waiver allows for a refund of 2 months of back premiums with no requirement to repay. Both of these options can be pursued simultaneously, and then they, provide pathways to regain some financial stability after getting those disruptions in their premium assistance. There is a consumer handout linked at the bottom here, just with providing all of that information in an easily digestible way. And as mentioned, as mentioned by Katie earlier, this is a long list of resources some that were included throughout the presentation. And we also encourage you to take a look at our newly updated website, which includes a lot of additional resources and recordings of past presentations. So I know we have gone over the hour, so I do want to provide to those who may be waiting on that CLE information, which will be sent to you in email tomorrow. But just in case, I'm going to go ahead and provide that the reference number now. That's 2410887N as in Nancy, 2410887N. And this is Hot Topics in Medicaid Eligibility and Appeals. This should provide a 1 credit the basic CLE. And so just here, we have our contact information, a link to our online intake form. I won't get into it now just for the sake of time, but this is a little blurb about my fellowship project that has been sponsored by the Borchard Foundation Center on Law and Aging. So you feel free to contact me if you have questions or interest related to the topics I'm covering that I'll be addressing with my project. I also want to quickly highlight those who are interested in our work that we have pro bono opportunities available at FHJP, which are being managed by our pro bono director, Ronnie Graham. And we have the QR codes and links to our intake, to the intake form here on this website, and the slides I've included in the chat, a link to that, as well as they'll be available to you on our website. And so now, just want to invite Katie back to help field any questions that may have come up.
And I see just one, Nicole, and it's just to repeat the CLE number, which I will say also, just as Nicole said, even if you didn't get it today, it will be emailed out to you tomorrow.
And I'll include that in the chat now.
Perfect. Thank you. Sorry again for going over. That was absolutely my fault. But thank you guys for joining us today. And please reach out if you have Medicaid related questions. Thanks, everyone. Take care.